So, do we need to use antibiotics in pediatric dentistry? Well, definitely, because there are over 500 species of bacteria found in oral cavity. Fortunately, only few are hostile, and these organisms can cause infections where antibiotics can become sometimes life-saving. And in studies, it has been found out that about 7 to 11% of global antibiotic use in children is due to the prescriptions by a dentist. And in a study done in 2015, 66% of dental prescriptions carry an antibiotic either alone or as a combination. Antibiotics are not only used in therapeutic use but as prophylactics during procedures indicated to prevent other systemic illnesses. And special characteristics in children like the extra body odor or increased bone sponginess allows faster spread of infection. So you might need to use antibiotics more in children rather than in adults. When you look at the antibiotic prescription trends now, from the beginning of introduction of the antibiotic, the trend has been always upwards. But in recent studies, it has been seen that there's a very rapid increase in especially the low middle income countries like India, Pakistan and Sri Lanka, where there's a rapid rise during a very short period like 15 years, and some increments are more than 100%. And then we find that sometimes, although there is a rapid increase, not all antibiotic prescriptions are really necessary, because in a study done in 2002, it was found that 1 out of 3 prescriptions carrying an antibiotic was totally unnecessary. So 1 in 3 is a very high rate. And the problem of not having enough dentists has also contributed, because the WHO recommendation for ideal dentist population ratio is 1 in 7,500. But in some areas like rural India, there's only 1 dentist for 150,000 patients. So this means most of the oral pathologies may be handled by non-dental practitioners who may use antibiotics unnecessarily because they don't have knowledge on interventional dental procedures. Therefore, the topic now turns towards another area called the rational use of antibiotics. So rational use of antibiotics means, yes, when there is a real indication you use the antibiotic, but whenever there is no indication for antibiotics, you do not unnecessarily use the antibiotic. So how can we rationally select an antibiotic or use an antibiotic? Well, first of all, you need to identify whether there is a need for antibiotic. If there is a need for antibiotic, you need to find the best antibiotic. Now, best does not mean always the most expensive or the most powerful antibiotic. There are different criteria which we will come to later. Then once you select the best antibiotic, you need to select the correct duration, which should not be too short or too long. And then whenever possible, use cultures or sensitivity patterns to find the ideal antibiotic for the organism isolated. Now this is summarized in the 4D principle in antibiotic prescription. And there are 4 Ds: the right drug, right dose, de-escalation to pathogen-specific drugs. So that means you can start with a drug which is empirical use. You guess an antibiotic at the beginning, but once you have the cultures and sensitivity pattern, you de-escalate to the pathogen-specific drug, and then you decide the right duration. If you get all 4 Ds correct, you are using antibiotics rationally. So how do you select the right drug? The best antibiotic will be, always try to select an antibiotic which has a narrow spectrum as much as possible for mild to moderate disease. But if you are dealing with a systemic infection or immune related problem, or if you are dealing with a very potent pathogen, yes, you might go for a broad spectrum antibiotic. The antibiotic should be cost effective, low side effect profile, and having minimum drug-drug interactions. Now these are common for adults as well as children, but when it comes to children alone, these three criteria are also important. The antibiotic should be palatable. It should have a good smell, good taste, color and texture. Frequency of dosing. In children, if you have less doses per day, much better, because if you have too many doses, you will end up with poor compliance. Then there should be a variability in preparation. Some children like tablets, some like syrups, and some like chewable tablets. If antibiotic is palatable, has a patient appropriate dosing schedule and come in variable preparations, then that will be a best antibiotic for children, because some antibiotics are there which fulfill all these 5 criteria, but they have a very bad taste, or the dosing frequency is too high, or they come only in tablet forms. So then in that situation, even if they have these features, it will not be the best drug or the right drug, because it doesn't give rise to better compliance by the child. So you have to pay close attention not only to these factors but also to these latter factors which determine the compliance of a child. Then indication for antibiotic use, there are different guidelines, but I am going to talk about the American Academy of Pediatric Dentistry guidelines, which is commonly accepted all over the world. And according to these guidelines, antibiotics are not indicated in any infection confined to the pulpal tissue or whenever there is a chronic abscess or necrotic tissue. The explanation is simple. Whenever there is no blood supply, antibiotic access is blocked. Therefore, no point in using antibiotics. In situations where there is contamination, acute facial swelling of dental origin or immunodeficiency states, or when there are systemic signs present, you can use antibiotics. Now this table will give a more elaborated indication and non-indication list. If there is pyrexia within the 24 hours indicating a systemic response or systemic symptoms, or trismus which is indicating spread to perimandibular spaces, then you can use antibiotics. You can use antibiotic for prophylaxis, which we are going to discuss later, or in a child with any form of immunocompromise. But for simple conditions like pain, edema and redness, which are due to inflammation, all you need is a painkiller and an anti-inflammatory drug, but not an antibiotic. Whenever there are abscesses or draining sinus tracts, you might need antibiotics, but the best treatment will be incision and drainage or surgical removal of the focus of infection. So in that case, the best antibiotic is actually the surgical intervention. Then in these conditions, irreversible pulpitis, chronic apical abscess, acute apical periodontitis, acute apical abscess without systemic effects, eruption and pubertal gingivitis. Now according to these guidelines, in these conditions antibiotics are not indicated even as an adjunctive therapy. Right? Adjunctive therapy means as a help to the surgical procedures. What the guideline says is, if there is no evidence of systemic involvement or spread to other tissues, you don't need to use antibiotic even as an adjunct. Then we come to the common antibiotics which are used in dentistry. First you get the first line antibiotics like amoxicillins and penicillins, amoxicillin clavulanic combination or co-amoxiclav, and metronidazole. When the patient does not respond to first line or develop allergies, you need the second line antibiotics like clindamycin, cephalosporins and macrolides. So now how to select the right dose? We have select the right drug. Now the dose. You can use the British National Formulary, which is the commonly used book for selecting doses, but I will give you a rough, easy to memorize guide for these antibiotic dose calculation. For amoxicillin, co-amoxiclav and cephalosporins, In children below 40, you use a dose of 20 to 40 per kg in 3 divided doses. For above 40 kgs, you can use 250 to 500 milligram every 8 hours. Okay. Alternatively, you can use a slightly different regime where you go for a slightly higher dose, 25 to 45 milligram per kg, but in 2 divided doses. This is ideal for mild infections because the dosing has gone down. Therefore, you get better compliance and low side effects, but the efficacy is same. For children, this dosing schedule may be better than a 3 divided dose dosing schedule. Metronidazole and clindamycin, similar, they come in 3 dose schedules. Metronidazole, mild cases, you can use 20 to 30, in severe cases 40. Clindamycin, you go for a slightly lower dose, 8 to 20 milligram per kg per day in 3 to 4 doses. Okay. So you can see that 20 per kg is same for all 3 drugs. But in clindamycin, 20 per kg is high dose. In metronidazoles and amoxicillin and cephalosporin, 20 per kg is a low dose. But sometimes you need to change the dosing regime. Okay. Commonly due to drug interactions, like for example NSAIDs or non-steroidal anti-inflammatory drugs, they can lower the effect of antibiotics, so you might need to use a slightly higher dose of antibiotic. Anti-epileptics, you can have both features. Sometimes antibiotics can lower the effects of anticonvulsant or increase the effects of anticonvulsant, which can result in seizures and neurotoxicity respectively. Anti-failure drugs like furosemide can increase the nephrotoxic effects of cephalosporin. It is very rare in normal children, but in children who are already having underlying renal insufficiency, this rare nephrotoxicity can occur. If a child is having any underlying medical illness like renal or liver disease, you might have to reduce the antibiotic dose. So we'll go to the interactions and medical conditions one by one for each antibiotic. For amoxicillins and penicillins, severe drug interactions are very rarely reported, but mild to moderate interactions can occur with azithromycin, clarithromycin and erythromycin. So if you are giving these 2 drugs together, which should not happen commonly, you might end up with mild to moderate interactions. And there are certain disease conditions where amoxicillin and penicillin should be used with caution. For example, if the child has a colitis, the condition can get worse if you use amoxicillins or penicillins. In chronic renal insufficiency, the drug excretion is delayed, so you might have to lower the dose of the antibiotic. In diabetes mellitus, in children with diabetes mellitus, amoxicillin in urine can give false positive results, during urine sugar testing. Infectious mononucleosis and amoxicillin. When you give amoxicillin to infectious mononucleosis, which is caused by the Epstein-Barr virus, then you can get a rash, which is benign, but unfortunately this can be misinterpreted as allergy to amoxicillin, and a patient might not use amoxicillin in the future unnecessarily because they have misinterpreted the rash as an allergic rash. Infectious mononucleosis is a viral condition which involves the pharynx. Therefore, best thing is not to use antibiotics. Cephalosporin drug interactions, severe interactions, again very minimal and rare. Mild to moderate interactions can occur with other antibiotics like penicillins and flucloxacillins or oral contraceptive pills. Disease conditions where you have to be careful when using cephalosporins. If there are chronic renal diseases, the drug elimination is slow. Therefore, you might need to use a lower dose to avoid cephaloxacin toxicity. In chronic liver diseases, prolonged use of cephalosporin can result in prolonged PT-INR levels. Macrolides can inhibit the intestinal and hepatic microsomal drug oxidizing enzymes. The common is cytochrome P450, CYP1, 2 and 3. Now, what is the importance of this inhibition? Now, these cytochromes are important in metabolizing many other drugs. So, when you inhibit these cytochromes, the other drugs which get metabolized does not get metabolized, and they can accumulate into toxic levels. For example, antiepileptics, neuropsychiatric drugs, and sedatives, they are metabolized by the cytochromes, and when macrolides are used together, these cytochromes get inhibited and antiepileptic levels can go up. The neuropsychiatric drugs can go up, sedative levels can go up, and this will result in severe neurotoxicity or severe depression when it comes to sedation, neurodepression. So it's very important that whenever a child with conditions of epilepsy or children with autism, they may be on neuropsychiatric drugs. If they come to your practice and if you are using macrolides, you have to be careful. Best thing is to discuss with the pediatrician and lower the drugs or lower the doses of these second drugs if you really have to use a macrolide in these children. Then finally, the right duration. All guidelines, medical and dental, recommend that antibiotics should be given for at least 3 days after resolution of symptoms. Right? And many prescriptions nowadays, prescribers give the drug only for 3 days. It may be okay in mild infections, but remember, for proper use, these at least 3 days should be after resolution of the symptoms. So, for example, if it takes, for the resolution of the symptoms, if it takes 2 days, then you need to give another 3 days after resolution of the symptoms. So the total duration will be 5 days. If your duration is too long, there will be more side effects, more resistance, and drug incompliance. If your duration is too short, there can be again resistance and incomplete cure. The current trend is we prescribe too many antibiotics unnecessarily and try to cut down the duration again unnecessarily. But our future trend should be that we limit our prescription on antibiotics, but whenever we are using the antibiotic properly, complete the course rather than unnecessarily cutting down on the duration. Dangers of antibiotic overuse in children. What are the dangers? Why are we so worried about antibiotic overuse? Well, you can encourage multi-drug resistance if you unnecessarily overuse antibiotics. There is risk of developing non-communicable diseases like diabetes or asthma when you use antibiotics at an early stage of development. When you give antibiotics to the developing child, you alter the normal gut flora, and when this happens in childhood, you can have a risk of future obesity, candida superinfection, and photosensitivity. Overuse of amoxicillin in infancy might give rise to developmental enamel defects of molar and incisor teeth. These are dangerous side effects, but even simple side effects like GI side effects, disruption to feeding pattern, they are very important. And do we have evidence that we are overusing antibiotics in dental practice? Yes, there are definitely evidence. Review data from North American study shows that 11 to 40% dentists did not adhere to guidelines set by the American Academy of Paediatric Dentistry. And pediatric dentists showed a better compliance than general dental practitioners. Similar patterns have been found in India, Saudi Arabia, Jordan, and Croatia, where all of them reported high rates of non-adherence to local antibiotic guidelines. So research suggests that we are not using antibiotics properly. And in all the above studies, there was one important finding. Most dentists had adequate knowledge of antibiotics, but they did not have adequate knowledge on guidelines of antibiotics. So they knew the antibiotic well, but did not know the guideline properly. And use of cultures and sensitivity pattern was very minimal. So most dentists tend to give antibiotic which is what we call as an empirical antibiotic. So you guess and give rather than finding the organism and give. There is more alarming data coming from UK. In a study done in 2016, the general practitioners, not dentists, the general practitioners, general medical practitioners tend to overuse antibiotic for oral conditions rather than referring to a dental practitioner. And this is not a minor number, 57% of consultations regarding oral conditions. And the reasons given is that by giving antibiotics, they can cut short the illness and avoid a visit to the dental practitioner. And in countries like UK, visit to the dental practitioner may be difficult or may be costly. So there is a trend among general medical practitioners to overuse antibiotics rather than referring to a dental practitioner. In USA, 2 million people are infected by an antibiotic resistant organism every year. So definitely we are overusing antibiotics. So why are we overusing antibiotics? Well, number one, lack of knowledge on definitive indication for antibiotic use or guidelines. Then one common problem, not only among dentists but among medical practitioners, we tend to diagnose pain due to inflammation as an infection. We mistakenly diagnose pain due to inflammation as an infection. Therefore, we give the painkiller and an antibiotic. Both are given, and usually the antibiotic is given as just in case antibiotic. Okay. And sometimes there's a common myth that a prescription is incomplete without an antibiotic. And finally, pressure. Pressure comes in three different ways. Parental pressure, where the parents generally believe that antibiotics are better than interventions. Parents believe that giving an antibiotic is better than doing a dental interventional procedure. Then there's patient pressure, like children, especially children who are having conditions like autism or ADHD, attention deficit hyperactivity disorder. They are very difficult to control during dental procedures. Now, you know, as dentists, you have found out that even normal children do not like dental procedures very well. For these children, autism and ADHD, the procedures are not tolerated at all. So what happens is the practitioner want to do a dental procedure, but there is pressure. The patient is not very cooperative. Therefore, to avoid intervention or to delay the intervention, you might tend to prescribe an antibiotic and send the patient home. Then the third pressure is technical pressure, where you have lack of time to perform procedures or lack of facilities or lack of theatre space. So to buy time or to delay this, you use antibiotics. So these are the common reasons why we overuse antibiotics rather than going into definitive curative procedures. Then side effects of antibiotics. Now we are overusing antibiotics. So what are the side effects if you continue to overuse antibiotics? Is it only resistance? No, there are some side effects. General side effects are there. With regard to antibiotic use, general side effects include non-specific GI symptoms like nausea, vomiting, loose motion, pain, or specific side effects like post-antibiotic colitis, allergies, and sometimes very rarely anaphylaxis, superficial fungal infections, and loss of taste or appetite. So these side effects can get, a child can get these side effects more and more if we tend to overuse antibiotics. There are rare and more specific side effects which we need to be aware of. For example, hepatotoxicity, which is uncommon but not impossible. They can be seen with penicillins and macrolides. Seizures and hallucinations, usually with old macrolides like erythromycin and metronidazole. Cardiac arrhythmias, again with old macrolides. Stevens-Johnson syndrome, metronidazole is the common source, but any antibiotic can cause this. Drug-induced immune hemolytic anemia and pancytopenia. These are rare, but if you tend to overuse antibiotics, these rare side effects might become more common than we think they are. So how to avoid overprescription? Well, you have to be thorough with the guidelines, read guidelines and find out the indications for antibiotics and contraindications. Once you identify the correct indication, apply the 4D principle, and if you have forgotten it, I will put it back again. The 4D principle is right drug, right dose, de-escalation and right duration. Now we go to the final part of the lecture. Antibiotic prophylaxis in dentistry. Now all this time we have been talking about therapeutic use of antibiotics or treatment. Prophylaxis. What is prophylaxis? Prophylaxis is you are giving an antibiotic to prevent a future potential infection. Now earlier guidelines, judicious use of antibiotic prophylaxis was encouraged, but because of these unnecessary use of antibiotics even as prophylaxis, antibiotic associated side effects and resistance has gone up. Therefore, the current guidelines, well, they recommend antibiotic prophylaxis, but there are limitations, and antibiotics are used in a restrictive manner. Newer guidelines give more emphasis on maintaining good oral health and routine dental examinations, which will reduce the bacterial load in oral cavity. So if you maintain good oral health and routine dental examinations, then the oral cavity becomes a healthier place. Therefore, the invasive dental intervention need will be reduced. And when you are doing these invasive procedures in an infrequent manner, the need for antibiotics as prophylaxis will also be reduced. So there are several guidelines, but I will compare two guidelines. The first guideline is the AAPD guideline, or American Association for Pediatric Dentistry guideline, which was last revised in 2019. These guidelines are based on American Heart Association and American Dental Association recommendations. These guidelines recommend antibiotics for patients with highest risk of developing infective endocarditis, and these patients with the highest risk include unrepaired cyanotic heart disease, completely repaired heart defects with prosthetic devices during the first 6 months after repair, repaired heart defects with residual defects adjacent to the prosthetic device or patch. If a child has previous infective endocarditis, cardiac transplant recipients and prosthetic cardiac valves, then antibiotics are recommended. All dental procedures that involve manipulation of gingival tissue or the periapical region of the teeth or perforation of the oral mucosa, an antibiotic has to be provided before the procedure. The other non-cardiac conditions which need antibiotics include immunosuppression secondary to HIV, severe combined immunodeficiency, then history of head and neck radiotherapy, autoimmune disease, sickle cell disease or splenectomy, hemodialysis and chronic high-dose steroids. For non-valvular devices or vascular shunts or VP shunts and cardiac electronic devices, antibiotic prophylaxis are given only during the time of insertion or implant. Antibiotic prophylaxis are not indicated during future dental procedures. So whenever you are implanting, yes, you need antibiotic prophylaxis to prevent infection, but once a device is in situ, then in future dental procedures you do not need antibiotic prophylaxis. The commonly used antibiotic prophylaxis agents are given in this slide with the respective doses. Then the second guideline is the NICE 2008 guidelines, where the NICE guidelines or National Institute for Clinical Excellence guideline, they do not recommend antibiotic prophylaxis for infective endocarditis in patients undergoing dental procedures. Now, the American guideline has some conditions like the unrepaired cyanotic heart disease, but in this guideline, which came in 2008, they recommended that antibiotics are not needed. Initially, this looked like a good move because with these strict rules, antibiotic prescription as prophylaxis dropped by 80% without any significant rise in incidence of infective endocarditis. But unfortunately, several cases of severe infective endocarditis were reported following dental procedures. And in 2015, 2 deaths due to infective endocarditis occurred after dental procedures, which led to petitions against the NICE guidelines. So therefore, in 2016, the guideline panel under NICE changed the guideline. They said that the NICE guidelines do not recommend antibiotic prophylaxis routinely for infective endocarditis in patients undergoing dental procedures. Now, putting the word routinely, they may have mentioned that individual case-based antibiotic use is accepted. So what they say is routinely you don't need to put an antibiotic, but if you think that this certain patient is having a higher risk than the others, then before the dental procedure you can use an antibiotic. So it's a more individual based decision rather than a general decision. But in UK, where NICE guidelines are used, a survey, this is a very important survey, this is a very important survey which shows that 36% of dentists had provided antibiotic prophylaxis during procedures even though the NICE guideline says not to use. And in a questionnaire, 25% dentists have responded saying that they prefer to give prophylactic antibiotics for patients with prosthetic heart valves, although the NICE guideline says not to use. So practitioners in UK who are following NICE guidelines are actually not adhering to these guidelines. So there are differences in guidelines. What is best for Sri Lanka? Well, we have many complex cyanotic heart diseases which are not surgically corrected, and the oral hygiene of kids compared to the Western community is not great in Sri Lanka. We don't have the optimum standards. Therefore, strict guidelines like NICE 2008 are not applicable to Sri Lanka. AHA guidelines are better, but the ideal guideline will be a local guideline which is based on evidence, research and long-term experience, which is yet to come. So we come to the end of the lecture. So I will, if there are any questions, I will entertain them during the discussion period. Thank you.